Due to the July 12th meeting of the New England Comparative Effectiveness Public Advisory Council. The subject of today's meetings are emerging therapies for moderate to severe plaque psoriasis and elagolix for treating endometriosis. I'd like to begin by having the CEPAC panel introduce themselves.
Hi, I'm Teresa Fama. I'm a rheumatologist here at Central Vermont Medical Center, which is part of the UVM Health Network. And I've been on CEPAC for many years.
Hello, I'm Claudio Gualtieri, advisor with the Campaign for Action at AARP, working on health equity, building a culture of health, and improving healthcare access and nursing care.
Hi, I'm Ed Westrick. I'm a primary care physician in Rhode Island. Red? That's better. I'm a primary care physician in Rhode Island and a former pharmacoeconomist.
I'm Steve Kovic. I direct our graduate program in health outcomes research at the University of Rhode Island.
Good morning. I'm Stephanie Nichols. I'm an associate professor of pharmacy practice at Hudson University and a psychiatric and substance use disorder pharmacist.
I'm Brian O'Sullivan. I'm a pediatric pulmonologist at Dartmouth-Hitchcock Medical Center and professor of pediatrics at Geisel School of Medicine at Dartmouth.
Jane Ryer, I'm director of the New Hampshire Citizens Health Initiative. It's a statewide health improvement collaborative, part of the University of New Hampshire's Institute for Health Policy and Practice.
Jason Waspi, I'm vice chair of CEPAC. I'm a cardiologist at Mass General Hospital of Boston. I'm director of outcomes research at Mass General Hospital Heart Center and assistant professor at Harvard Medical School.
Hi, Reverend Albert Whitaker. I'm the Northeast Region Director for the American Diabetes Association.
I'm Claudia Gruss. I'm a clinical educator and with Western Connecticut Health Network, and also a practicing gastroenterologist and internist. I'm also the chair of the quality committee of CT Health Link, which is a health information exchange.
Thank you. And I'm Rob Azeltine. I'm professor and chair in the Division of Behavioral Sciences and Community Health at the UConn Health Center. At the beginning of every CEPAC meeting, we want to ensure that all speakers disclose any financial relationships with the healthcare industry. Every member of our New England CEPAC panel who is present today has met the ICER conflict of interest policy. We'd like to give an opportunity, though, for our panel members to update or offer any updates to that conflict of interest policy. Seeing none. Other speakers, including our experts and individuals making public comments, should announce any financial relationships with industry when they speak. We will also present this information publicly on slides. And now I'd like to introduce Dr. Dan Ohlendorf from ICER.
Thank you, Rob. Good morning, everyone, and welcome to the New England CEPAC meeting focused on our update of targeted immune modulators for plaque psoriasis as well as elagolix for endometriosis. I've got two mics, so you should be able to hear me fine. So I wanted to just kind of set the stage for our discussions today. We often tried to set that context by using actual quotes or interactions that we've had as part of our report processes. And so I want to read a couple of quotes to you to kind of describe what we're talking about in terms of psoriasis. And just in terms of the order of the day, we'll be dealing with the psoriasis topic this morning, and then we'll be focused on elagolix after lunch. So for psoriasis, there is a quote from the National Psoriasis Foundation that was part of the public comment process for this report, describing in part our initial report. The 2016 economic analyses resulted in incremental cost-effectiveness ratios across all agents that were well aligned with commonly accepted thresholds for cost-effectiveness. ICER's policy recommendations encourage payers to abolish or limit the use of step therapy for these treatments. Yet it is unfortunate that since the last report, it appears the access problem may have gotten worse for individuals living with psoriasis. A quote from Fierce Pharma, a kind of Wall Street-focused newsletter. The psoriasis field has grown increasingly crowded over the last few years thanks to a slew of biologic approvals. Novartis' Cosentyx kicked off the party back in early 2015, only to be followed by Eli Lilly's Taltz, Valiant Silique, and Johnson & Johnson's Tremfya. And therapy areas that see waves of pricey new products tend to be the ones payers target to keep costs down. So a big highlight as part of our initial 2016 review were the challenges to access that patients had, given the plethora of drugs available and some of the entrenched relationships with some manufacturers and payers. So this is a challenge that we'll be touching on at various points during the morning. We'll have some discussion about it and reflection, time for reflection at the end. But that's one of the reasons to set the stage here. In general, however, we're also here for reasons that we're always here: increasing healthcare costs that affect individuals, state and federal budgets, new mechanisms of action that often raise questions about appropriate use and cost, and here we do have a new class of agents to be talking about as well. Patients, as discussed, have difficulty accessing drugs. Step therapy protocols, we'll talk about that too. Requirements to switch drugs as patients switch insurance. High out-of-pocket costs, a challenge that's really faced across clinical areas. There's a need for an objective discussion and evaluation of the evidence on effectiveness and value. That is what ICER is all about. And this is ICER's first, quote, condition update, an opportunity to evaluate new therapies, update evidence on established therapies, and track some of those policy and coverage changes that I alluded to. So, as Rob mentioned, this is the New England Comparative Effectiveness Public Advisory Council, one of ICER's 3 regional public deliberative programs. But for those of you not familiar with ICER, why don't I spend a few minutes talking about us? So, first, there's a graphic that is also available on our website to describe how we approach our work in public and public deliberation. So we have several different sources of funding. The majority of the funding that we get as an organization is from nonprofit foundations, chiefly the Laura and John Arnold Foundation, the Blue Shield of California Foundation, and the California Healthcare Foundation. That funds our project work. We also get equal amounts of funding from manufacturers and payers, but that's to support a separate set of dialogues around healthcare policy. We have an annual policy summit that those parties come to. We also have various policy discussions during the year, but we keep it separate from this project work that we're discussing today. We also have some residual funding as well from state government contracts. So let's talk about how, at least in this morning's session, the report for plaque psoriasis was developed. So we always go through a scoping process to try to get guidance from patient groups and patient representatives, clinical experts, manufacturers, and other stakeholders. That's part of the process, the initial part of the process. There's an internal ICER analysis, so led by the team at the table, of the evidence. We also worked with the University of Washington to do the cost-effectiveness modeling for this review, as well as the initial review in 2016. We have several opportunities for public comment, both on our draft scope as well as on our draft report, and so we integrate those considerations from public comment into revising both the scope and the report. And then there were expert report reviewers as well. So 2 of those reviewers are here today. Dr. Alexa Kimball and Leah McCormick Howard. So Dr. Kimball is from Beth Israel Deaconess Medical Center, and Leah is from the National Psoriasis Foundation. We also had Dr. Joe Marola as well as an expert reviewer. And so we were fortunate to get their guidance and counsel. Their comments should not be considered an endorsement of our report, but their review was quite useful in making changes to the ultimate evidence report that was distributed for this meeting. So let's talk a little bit about how we typically structure our reviews then to support today's voting and any policy discussion that ensues. So our goal with any report is to produce information that can inform a discussion about achieving sustainable access to high-value care for all patients. So we are trying to keep an eye on a number of things to get to that. And so there's really two major supports for this. One is what we call our long-term value for money component of the assessment, and then we also deal with the construct of short-term affordability. So long-term value for money itself has several components. The first of these is a very clear-eyed look at the clinical evidence. What is the clinical evidence telling us? What do we know? What do we not know? Where are the key uncertainties? We also do a review of long-term, typically lifetime, cost effectiveness. So trying to extrapolate information from the clinical evidence available to understand in a comprehensive way the costs and effects that could occur over the long term. And these are all the costs. We're not just talking about drug costs here, but if the use of drugs leads to offsets in medical services, for example, we would capture that as well. But we also recognize that neither of these analyses, however well they're done, can capture everything about the lived patient experience with the condition. And so we also try to capture any other benefits or disadvantages that may not be well measured in the evidence or able to be captured in the modeling, as well as some contextual considerations. And so examples of other benefits or disadvantages might be more convenient dosing or a more convenient setting of care. Contextual considerations might be a significant public health burden from a condition or a very high severity of illness. So that's long-term value for money. Short-term affordability is an important construct not as a measure of value, but as a measure of the health system's ability to absorb the additional costs associated with a new therapy. That new therapy may be of high value to the individual patient, but may pose specific budget issues to a health system. And so we want to try to capture that as well, more as a guide toward policymaking and decision-making around trying to ensure that the right patients get the drug at the right time. So let's talk briefly about the morning. So I'm almost finished with the welcome and opening remarks, and we'll get right then to the presentation of the evidence and the economic modeling. So Dr. Rainer Banken will present the clinical evidence to you, and Dr. Dave Veenstra will present the cost-effectiveness methods and results. We'll then have time for public comment. These public comments will be both from individuals of the general public, as well as we'll have comments from several manufacturers. There will be a brief manufacturer panel and discussion following those comments. Then we'll have the votes on effectiveness and value. And we'll have some time for reflection from experts as well as the New England CEPAC panel before we break for lunch. So of note, there is no roundtable discussion as part of this topic, as it's an update from a previous review. But again, we should have some time to at least get some of those reflections out there. So in terms of clinical experts who will be available clinical and patient experts who will be available to answer questions and interact with the panel at several points during the morning, I'd like to reintroduce Dr. Alexa Kimball from Beth Israel Deaconess Medical Center, as well as Leah McCormick Howard from the National Psoriasis Foundation. So they'll be here as a resource, and we're grateful for your participation. So without further ado, let me turn the mic over to Rainer.
Does this work with the mic? You hear me well? Yes? Okay, great. So I'm going to talk about the evidence review. The key members of our team were Felucio, who is here, Alexandra, who is our NMA expert, who isn't with us, and Catherine, who is also here. As to this report, we do not have any conflicts of interest to report. So why are we having this condition update? We get some comments, well, it's too early. Well, it's always too early until it is too late. So we decided to have this update. First of all, it's an update from the 2016 CEPAC meeting. I think most or nearly all of the members of the CEPAC meeting were there, so you know about the topic. The main reason is for the update, we have got a new class of therapies the IL-23 therapies. There are 3 new drugs that have been approved, and we have got a new indication for a TNF inhibitor. So we looked at this new evidence, but we also updated the clinical data and the costs for the therapies, for all of the therapies that were reviewed in 2016. One slide on topic, on context. So psoriasis is an autoimmune disease that causes itchy, red, scaly, raised plaques. It affects around 3% of the population, so it's a common disease. It is associated with other autoimmune diseases, metabolic syndrome, cardiovascular disease, and in up to 30% also with psoriatic arthritis. There is no generally agreed upon definition or clear definition of what is considered as moderate to severe, but generally when we talk about moderate severe, that's what we're talking about for the indications of all the drugs. Moderate to severe is considered when it's affecting 5 to 10% of a patient's body surface, and when the lesions significantly reduces the quality of life. The effects of patients can be profound. I think everybody must be aware that this is not a cosmetic disease, because for many, it's just some scales. No, it's more than that. It has profound impact on life. It's a lifelong disease also. Once it appears, it stays with you. There is a high likelihood of having depression, anxiety, and suicidal ideation. And it's also important to consider the impact of lesions in particular areas: nails, scalp, face, flexural areas, palms, soles of feet, and genitals, which has a profound impact on the quality of life. The management, one style of management. So you're starting with topical therapies, emollients, topical steroids, and others, which are effective for about 70 to 80% of the patients. There are older systematic therapies which are available, cyclosporine, methotrexate, with often severe side effects. You've got phototherapy, where you have to go there every day to have this phototherapy, or every couple of days. And it's difficult to apply phototherapy, for example, in scalp areas in some of the areas. And then you've got the targeted immunomodulators, which are the subject of today's meeting. So the first 3 bullet points are the non-targeted therapies. The fourth one are the targeted therapies. So the TNF inhibitors have been around since about 10 to 15 years. The class of IL-17 inhibitors have been introduced 2 or 3 years ago, and they were the subject of the 2016 meeting. And now we have got the new class of IL-23 inhibitors. IL-23 are higher in the cascade. So IL-23 say they trigger the IL-17 release. So it's all a cascade of inflammatory response. We got lots of input from the patient groups, especially the National Psoriasis Foundation. It basically reflects what we heard in 2016. I don't think there has been very much evolution on the patient perspective on psoriasis. So one of the criticism of existing research is that the research is not patient-centered. For example, the outcome measures do not reflect very often itching, which is the most cumbersome symptom for patients, but it's not part of the PASI outcome measure. Also, a specific location, the locations I mentioned before, they are not measured in the usual outcome measures that are used for clinical research. The patient dissatisfaction, it's pure tolerability of some of the medications. There's especially a delay in diagnosis, so it takes some time till you get the diagnosis of psoriasis. There are specific challenges for Black and Hispanic patients. There's a higher prevalence. There's often more severe disease. but there is often more common misdiagnosis. Also a more frequent non-treatment. So generally, Black and Hispanic patients have a not as good diagnosis, and the treatment is not as good as for white. The treatments can be challenging. I mentioned phototherapy. You have to go there. You have to. So it's a challenge. A lifelong treatment with a specific challenge to getting the treatment, the appropriate treatment. Affect social functioning. For example, you are less likely to go swimming because you don't want to expose your skin. You are exposed to bullying, especially patients, children. People sometimes think it's infectious disease. So all these impacts. And there is a concern of lack of access. We heard about this in the beginning of the slides. The costs, the inadequate insurance coverage, and the challenge to get these drugs. And the National Psoriasis Foundation has shown that over the last 2 years, this actually did not improve very much. There are some best practice coverage of some of the insurers, but overall, the coverage has gone down and the cost, out-of-pocket costs, has gone up over the last years. Issues of focus. You have the information in the report, in the executive summary, and in the evidence summary that has been handed out. So I will focus especially on the questions that are relevant for the voting today. The scope is a population of adults with moderate to severe plaque psoriasis. The interventions are targeted immunomodulators. The comparators are placebo and head-to-head. And these are the main outcomes. PASI, that's the main outcome that's being used. You've got the PASI level between the 0 and 72, I think, as an absolute level. But when you're talking about PASI 50, 75, or 95, or 100, it's a reduction in the PASI score. So you go from the initial PASI score and how much was it reduced, and that's the PASI we're talking about. So PASI 100, it has completely disappeared. PASI 75, it has gone 75% from the initial PASI score. The PASI score does not measure specific areas. It does not measure patient-reported outcomes such as itching. Similar scales are the physician global assessment and the investigator global assessment, which are variations. You've got patient-reported outcomes, dermatological life quality index, what's index education, I think. So this is the main tool that's being used for quality of life measures, patient-reported. And you've got other symptom measure scales. We also looked at treatment-related adverse events. So in the 2016 review, we had 34 key trials. For the current reviews, we had 48. So of these 14 new trials that were added, 10 were related to the 4 new drugs of interest, and 4 were additional trials that were identified on the old drugs. The 4 new trials are listed on the slide. So these are the phase 3 trials on the new drugs with the trial names. The inclusion criteria was for adults. The body surface area had to be more than 10%. The PASI score was more than 12, the absolute PASI score. Patients had to have at least 6 months of plaque psoriasis diagnosis, and they had to be candidates for phototherapy or systemic therapy. Other treatments were prohibited. If there was a prior immunomodulatory therapy, there was a washout period. In recent trials, between 20 and 40% of patients had used another immunomodulatory therapy before. Nearly all of these trials are short-term, between 12 and 16 weeks. The CLEAR trial, secukinumab versus ustekinumab, was a 1-year trial. These are the outcomes of the placebo-controlled trials. So you have a color coding, which we're going to use later on. So the first three are the IL-3 inhibitors, and the blue one, citolizumab, is the TNF-alpha. So all of the targeted immunomodulators had a significantly higher PASI 75, 1900 responses compared to placebo. All of the trials measured PASI 75 and 90. These are the direct comparative trials with PASI 75 and 90 outcome. For ustekinumab, you see data and confidence for the PASI 75 data. We requested them. They were used in the network analysis in the NMA, but they have not yet been publicly available. So ucalzumab was superior to adalimumab in 2 trials, tildrakizumab and 400 milligram citolizumab pegol was superior to etanercept in 1 trial each, and risankizumab was superior to ustekinumab in 2 trials. We did a network meta-analysis, so please have a look at this because I think it's a very good overview of the work that we did. So the lines you are seeing between the different, there are 12 agents in there. The lines you are seeing between the agent names, these are direct comparisons. And the more direct comparisons we have, the thicker the line is. If you do not have a line between 2 drugs, this means there has been no direct comparison, and we have performed an indirect comparison in the network meta-analysis. So, for example, if you look at risankizumab and tildrakizumab on the top, the IL-23 inhibitors, there has been no direct comparison between both. That's why you don't have any line in there. And the color coding is for the different classes of agents as indicated. I'm showing you the results of, we called it first a relative risk, but then we changed it for response rates. So when you were in the 2016 meeting, you had the same slide with the relative risk, but risk means a negative effect, a harm. What we are showing is rather a response rate. So compared to placebo, placebo is 0. So ucalzumab, for example, is 1670 times more effective than the placebo. So these are the 3 IL-23 inhibitors, the new class. Next one is the 4th one, TNF, with the new indication. And these are the existing TNF inhibitors. Here you're having, this is the one, the ustekinumab is an IL-12/23 inhibitor. The others are the IL-17 inhibitors. And the last one is the PDE4 inhibitor, apremilast. When we had a vote in 2016, the vote was to the effect that we are unable to distinguish the net health benefit among the IL-17 inhibitors. Today, we are not going to have a vote on the differences between the IL-23, but we are rather comparing the IL-23 to the TNF-alpha inhibitors. So these were the outcomes, PASI 75, which is the most commonly reported outcome. These are other outcomes that were considered in the direct comparative trials. So you see green, it goes in the same direction, and yellow is non-significant. We don't have any red in there. So the message is that the PASI, I remind you that this doesn't consider any specific surface areas nor pain symptoms, is comparable to the PGA, and DLQI, which does include the symptoms, for jukelsamab and risankizumab, for TILDRA, for the IgA and TLQI, there is it's not significant different from the placebo. And for certolizumab, we don't have any data available. There were other outcomes sometimes reported on productivity and other outcomes, but unfortunately these were not reported consistently among the different trials. Harms, a very important question. So we are separating induction period, which is the stabilization period, it's 10 to 16 weeks for the long-term safety. So the serious side effects are rare, 2 to 4 compared to placebo. The other adverse effects were also basically comparable to placebo. And the discontinuation due to adverse effect was 0.5 to 1 to 3%. So very, very safe therapy with little side effects. The long-term safety, nothing particular to consider either. There have been some reports in literature that for some of the immunotherapies, there are immunomodulators, there may be more cancer, but it's increasing evidence showing that this is related to the disease itself and not to the treatment as such. Controversies, we had 16 out of the 48 key trials are head-to-head comparisons. So the majority of the evidence is based on indirect comparisons. Some of the outcomes that patients said were important were underreported. The clinical outcomes are based on short-term data, and the subgroup data were only available for placebo comparisons. So we were unable to define subgroups as some of the patients have requested, so the results, the evidence is applicable to the general populations of psoriasis patients. And unfortunately, there is no good evidence on choice of second-line targeted immunomodulators. Clinically, it's clear. It seems to be very clear. The experts will probably talk about that. Second-line, third-line, fourth-line, they are less effective. But there is no clear evidence on the sequencing and the effectiveness of these agents as a second, third, or fourth-line therapy. These are the evidence ratings. You've got the complete evidence ratings in the handouts, in the evidence summary. So I'm just showing the evidence ratings as relevant for the voting questions. So you have got the 4 new agents, with the indirect comparison being in blue, the direct comparison being in green. And for risankizumab, the comparison is based on conference abstracts. There are no publications available for that. So certolizumab, etanercept, 1 direct comparison, evidence rating C. Jukelsamab, 2 comparisons, daratumumab, B. Risankizumab, there is no direct comparison. Tildrakizumab, 1 direct comparison with a C+ for etanercept. All of the agents are administered subcutaneously, except for apremilast, which is oral, infliximab, which is IV. So subcutaneous is less burdensome, it has reduced complexity. Patients may favor the convenience of an oral drug. And the new class of drugs may offer new options for patients who did not achieve adequate control with the other agents. So there are specific clinical situations, for example, for inflammatory bowel disease, where the IL-23 inhibitors are of advantage. That's the main message of my public comments received. I resume this into 4 points. So I've been asked to include systematically other patient-reported outcomes. We reported them when available. Unfortunately, they are inconsistently reported, and as we see, PASI is rated very closely. As for the other subpopulations, we're limited by available data. We also were told that we should consider apremilast not viewing them as part of the target immunolators, but comparing them to the oral drugs. We decided not to change this because apremilast is a target immunolator and it has a similar clinical use, as well as the coverage criteria. They are part of the overall class, this class of drugs. We've also been asked to modify our NMA methods, especially the placebo adjustment. We added scenarios and sensitivity analyses, but they did not change the conclusions. Any questions?
Yes. Thanks, Rainer. If you could go back to the table of the ICER evidence ratings, so could you just comment a little bit on the quality of the evidence related to a couple of these? So, in particular, risankizumab. Now, you've given that evidence rating based on interactive comparisons that I just want to make sure it's consistent with where that evidence was derived. So that's coming from what we call the gray literature. It's from unpublished sources.
It was conference abstracts, but maybe for Lucia, do you want to comment on that? Or?
All the evidence
take micro, maybe.
We got them from conference abstracts. Yeah, no published literature.
Okay, so one thing I just would appreciate if you'd comment on. So our voting questions, when we get to that, ask us to evaluate whether the evidence is adequate to make a determination about that agent in comparison to the TNF-alphas. So unpublished data, in my mind, has a lot of problems. At least in terms of adequacy. It may, in fact, be better, but from the standpoint of the adequacy of the evidence, could you just comment on that?
I think we maybe Dan, you want to? We had lots of discussions on this issue, so maybe Dan is the best one to comment on that.
We can go through some of those nuances a little bit more. And one thing to think about here is that we frequently make use of unpublished but publicly available data like conference presentations, in part because of the timing of when we do our reviews. Often during the FDA review timeline, there's much that's not yet published. So the additional layer that we did take advantage of as well is the submission of some confidential data from manufacturers that is not in the public domain at all. So there's really three levels to think about. And in this case, with risankizumab still going through the FDA review process, in other situations like that in the past, it hasn't been uncommon to have gray literature essentially as our only source.
And I would just add to that in the case of risankizumab, there was also a published phase 2 trial that was consistent with the unpublished phase 3 trial. So that gave us more confidence in our evidence rating.
Sorry, in the general dermatology literature and conference environment, abstracts like these will be presented at large conferences because of the timing of the data being available. They are very carefully put out there because they don't want to put anything out from a phase 3 program into the public domain. And these often have an enduring citation, right? So they are in a symposium abstract. So while they are not the final manuscript and obviously don't contain enough detail, they would be very consistent with what that final would be.
Can I just ask a follow-up question? I think this is a critically important issue to raise given the circumstances here. So my understanding, maybe this is for Dr. Kimball or all the ICER experts too, there's still a regulatory apparatus that oversees these unpublished trial data, right? I mean, there's a data safety monitoring board and registered clinicaltrials.gov and so forth and so on, right? It's true, right? For academics that we take great faith in the academic process, which is, I think, appropriate. But there's also, there's sometimes published randomized controlled trials that are still problems with the database. The editors can't review everything that happened in this trial. But I just want to be clear from my own understanding that there is still a lot of oversight of the data that are published in the great literature. Or, sorry, I shouldn't say published, presented.
I mean, direct comparisons are best. Indirect comparisons are not as good as evidence. And then you go, it should be published. And if it's not published, there is this layer of confidence that you have in the data. And I think Rob is very right to attract your attention to these points. We feel that we can trust this information. That's why we put it there.
Yeah. I would characterize it as, rather than preliminary, it's abbreviated. So because of the context in which it's done in general, for again, phase 3 programs, for a small physician-initiated study, things could change in between the two, but typically, and I think the other thing to bear in mind is the FDA and regulators' request may be different sometimes than what's in the paper because there's different analyses that are presented based on those. So those don't always match if you look at the label and the published in the journal paper.
And for risankizumab, I forgot to mention that it has been submitted to FDA in April this year, and the approval date is in 2019. So that's where we don't have access to the report from the FDA, the data that has been submitted. All the other drugs are available currently on the market.
I would also want to point out that there's no peer review of the great literature, and it's what the sponsor wants out there, so we have to take it with a grain of salt.
Not to beat a dead horse, but one final note is that we consider many things part of the great literature, including FDA briefing documents and statistical reviews when they're available. So if there's an advisory committee and the materials prepared by that committee are available on the FDA website, we'll make use of them as well. Those documents are often more detailed than any publication that might actually eventually arrive. So there's a fair amount of nuance in how we deal with this information, but general concerns around what is peer-reviewed and what is not, and what is detailed and what is not, should be part of your thought process.
Yep. Oh. Is it an add-on comment to what Dan just said, or?
It's slightly different, but I just think an important context that you did a great job of summarizing. Since I've spent 20 years in this field. And I will just say, I have, in fact, as we get there, either I've spent most of my career doing clinical trials outcomes with a specialty area in psoriasis. I have used each of these drugs in either a clinical or research setting, so when we get to that point of why would you need 15 of them, I'm happy to discuss that in more detail. But I think important context is that the PASI 75 is stronger than a clinical improvement of 75%. The PASI score is not a linear scale because it is a composite measure. And so we have asked the questions of patients who have a PASI 75, what does that mean to you clinically? It's a 90% clearance. Right? So it really is a very substantial improvement. 75 kind of under-conveys what that means to patients. And then PASI 90 might be a little soft. And for someone who has had 40% of their body surface area covered, going from that to a PASI 75 or a PASI 90 is a remarkable clinical experience. So I just want to make sure that that sort of context of what a PASI 75 really means to patients is clear.
This is a different issue in regards to the network meta-analysis results. My question is, in looking at the results, the next slide. My question is, considering it's a meta-analysis, how much weight can we give to the comparison, first of all, within a class and between class in comparison of these medications? When is it statistically significant? Although I'm not quite sure whether that statistically is the proper terminology to use.
No, I think you're right. This is the right terminology to use to the statistically significant difference. For Lucio, you correct me if I'm wrong. So for the IL-17, it is about all the same if you consider the interval confidence interval. For the IL-23, you see the first two and you see the third one. There is a significant difference statistically between the first two and the third one.
So I just wanted to add to that if you look at table 7 in the evidence summary on the left side of your packet, you will see a leak table that helps you to compare the drugs to each other. The ones that are in bolded text in that leak table, those are the ones that have the credible intervals do not cross once. I mean, we assess it significantly different based on the result of the NNA.
So this is the leak table in your evidence summary.
So just to follow up to that, I think Claudia is raising an important point that will become even more important in our voting questions. So if we look at tildrakizumab there, where you say there's a statistically significant difference within that class, we're being asked to compare that to the TNF alphas. And we voted in 2016 that there was no difference among those three agents that we were evaluating at the time. But it does appear that there is quite a difference between adalimumab and etanercept. And so now, in the context of that voting question, this network meta-analysis really presents us with a little bit of a problem in understanding that. Can you maybe just elaborate on that, the question that Claudia raised about cross-class comparisons?
We did have another slide. We changed it. We should have kept it. We had some red boxes showing which are comparable. I think I would like to hand this over to Felucio, because she has been hands in into this and being really doing the network analysis. So Felucio, Dan, if you want to comment on this, is the
this is an important point because based on the additional evidence available to us now, there are some differences between the TNF-alpha inhibitors. And so when we're thinking about the voting, there are a couple of things to keep in mind. One would be when you have direct evidence available for that comparison to one of the TNF inhibitors. And the other would be in comparison to the best, if you will, of the TNF inhibitors in terms of PASI 75 performance, or whatever you're weighting in your own mind in terms of effectiveness. How does that comparison play out? So I think those are the two things to think about, because while there's not consistent in all of the comparisons between the TNFs, it's not consistently statistically significant. There are some significant differences. So it's mixed evidence, for lack of a better term.
Can I ask you a question, just sort of reflecting on some of the other questions about some of the points that have been raised about trials that are published and not published? It's a well-known fact that clinical trials are started and conducted and not published in journals. In many cases, they're registered in clinical trials.gov beforehand. And the concern is potentially that there is a bias of availability of evidence related to that. Do we know, and so presumably, I guess, does this evidence review take that into consideration, detect trials that may have been initiated and not published?
Yes. As part of our process, we review the clinicaltrial.gov to see if there are clinical trials that have started related to this drug and have not been published. And we report it as publication bias. And in this situation, we did not find any such clinical trial that is that.
Any other question before we go over to the modeling part? Anyway, any other questions arise later on, just ask them.
Great. Good morning, everybody. I'm happy to be here. Thanks for the invitation to come and present. So I'm David Veenstra from the University of Washington, and I led the modeling efforts in collaboration with Nathaniel Hendricks, who's a PhD student in our program, and he's the one who built the model and dug into a lot of the details. And we have no disclosures. So our objective here is to take a look at the economic value of these different agents, and I'm going to try to highlight in particular the value of the newer agents that are the focus of the meeting today. So here are the drugs that we looked at. Again, sortolizumab and guselkumab are the new agents for which we're able to assess value. The other agents, risankizumab and tildrakizumab, we don't have pricing on those yet, so we can't really evaluate their cost effectiveness, although we did run some threshold prices for those. So I don't want to spend a whole lot of time on the methods, partly because we used a similar approach to what we did back in 2016, but we built a a disease-based model to look at what happens to patients when they get these drugs, how do they respond, what does that mean to them in terms of quality of life, what are the impacts on costs, et cetera. And so patients could, so if this pointer doesn't really show up, sorry. Patients could start out in one of these 4 different health states based on their PASI response. And basically what happens in the model is patients who had a PASI 75 or higher, they stay on that drug. If patients were not able to achieve that PASI 75 or higher during the induction period, then in our base case analysis, we assume that about 75% of them switched over to a second-line targeted drug, so sequential therapy, and about a quarter of them then would go off of targeted therapy. And that was a slight update from our previous analysis where we assumed about only half of people went on to a second-line targeted agent. And then over time, for the most part, people that achieve PASI 75 or higher are pretty stable there. And over time, slowly, people do have some discontinuation, some transition to second line, or eventually transition to non-targeted therapy. We used a payer perspective. We assumed an average weight of 90 kilograms based on the trials. This analysis was a 10-year time frame for 2 reasons. One, previous analyses had used 10-year time frame. We wanted comparability. We also didn't really want to end up with a model. If we use a lifetime model, a lot of people end up on second-line therapy. We don't have very good data for effectiveness in second-line targeted therapy, so we want to focus on the first-line targeted therapy. Okay, let's see. I've covered a few of these assumptions. Let's see if there's anything here I didn't cover. I guess the only thing I'd mention is that we did not assume there was any effective treatment on mortality because we don't have any data indicating there is such an effect. I mentioned a few of these changes. We use slightly different set of drug options for second-line therapy because there are more options out there now. We also use slightly different quality of life estimates. I'll tell you a little bit about that. We calculated some different outcomes, months spent in time with PASI 75 or higher or PASI 90 or higher. One change we also made was instead of using class-specific drug discounts, we use drug-specific discounts, and that's because the data that we have shows that the drug discounts are different even within class. Like even within IL-17, drug discounts can vary from about 20% up to almost 40%. Okay, so those were the main changes, I think. In terms of how we set up this model with the sequential treatments, again, we did no analyses where it's just a monotherapy, really. There's always an option of a second-line treatment here. And so for guselkumab, we assumed that patients would be put on one of the IL-17 drugs. For the IL-17s, we assumed a patient would move on to guselkumab. This is based on discussion with our clinical experts. And then for certolizumab and all the other drugs, it was an average of the guselkumab and IL-17 drugs. The effectiveness data come from the network meta-analysis, which we just saw. And then also importantly for second-line treatment, we really don't have very good data at all for the effectiveness there. But we do notably have a lot more data than we did 2 years ago. And I think we have one randomized controlled trial, but other than that, a lot of it's kind of observational type study. But it does indicate that the response is lower with second line, and it's lower in people who failed first-line targeted therapy. So we estimate about a 10% absolute reduction in the PASI 75 or higher response for second-line therapy, second-line targeted therapy. The discontinuation rates, like how do patients do on these drugs? Do they stay on them? It's very complicated. There's a lot of data from a lot of different sources, a lot of different countries with different healthcare systems, different reimbursement policies. And it's very challenging to come up with a clear story that's evidence-based in terms of what happens. So the approach we used was we assumed, I think the main thing to pay attention to is that we assumed if they don't achieve a PASI 75 or higher during that induction period, they go off that drug and they go and they try a second-line targeted drug. Now, in the real world, they may, you might try boosting the dose, you might try just keeping them on that drug for a little while. But I think some of the discontinuation data we saw is that for drugs that don't have as high effectiveness, those discontinuation rates are definitely higher in that first year. So this first-year data is really driven by the clinical trial estimates. One difference is infliximab, which clearly showed higher discontinuation rates than would be expected based on just the effectiveness data during the induction period. And then in years 2 and beyond, we have some data pretty clearly indicating that etanercept and infliximab had higher discontinuation rates in the long term. And other patients who initially had pretty good response, they seem to have a bit lower and consistent discontinuation rate. Now, obviously, for some of these newer drugs, these are estimates, and we assume there was greater uncertainty around those because there are fewer data. It's also important to note that 2 of these drugs could be dosed based on weight, and for certolizumab, we assumed that half of patients got the lower and half got the higher dose, and for ustekinumab, we assumed 70% got the lower dose based on our assumed weight in the trials. And we looked at this in scenario analyses, so I'll come back to this a little bit. Here are our drug costs, and these are ordered based on increasing cost. You can see the 2 drugs that are the focus of this evaluation, guselkumab and certolizumab, down there at the bottom. They're the higher monthly cost, maintenance cost. It's important to note the guselkumab estimate. We used an estimated discount based on the discount we've seen for the other drugs in this class, so there's some uncertainty there. And for certolizumab, you also have this, what dose are they getting issue, so that's something to keep in mind. And again, we'll come back to that. Dr. Kimball mentioned that, when a patient achieves a PASI 75 or 90 response, that it's pretty meaningful to them. These are quality of life estimates, and basically what this says, if you go from a patient who's kind of not having very good response to patients who are having a 75 or 90 response, they get like about a 30% improvement in their quality of life. And that's a pretty big impact. That's pretty meaningful. So, and that was estimated from data that was submitted and evaluated for 5 different drugs. So it's an average across drugs. It's not treatment specific. It doesn't matter how you got to that state. That's the quality of life that was assigned. All right, well, let's talk about results. So here are our base case results, and I think the thing I'd like you to draw attention to is not necessarily the cost, but really the quality adjusted life years, which is our measure of effectiveness overall. And these are ranked by increasing overall effectiveness. And you can see that for our newer agents, certolizumab is kind of in the middle of the pack, and guselkumab is down here at the bottom of the table with the more effective drugs, similar to the IL-17s. Again, the costs are somewhat correlated with the quality adjusted life years, but not necessarily perfectly. We also have this other outcome that potentially is useful for maybe clinicians, but months spent in a response health state, essentially. Now let's look at the incremental cost effectiveness ratios. How much do you have to pay to buy one quality adjusted life year compared to a non-targeted therapy? And you can see that and again, these are ranked from lowest to highest. You can see that for roughly half these drugs, you can get that benefit of a quality for between $100,000 and $150,000 per quality. Okay, but you start to go over that kind of upper limit of $150,000 per quality from guselkumab on down, and you can see also for certolizumab, it had the highest ICER compared to non-targeted. And I'll show you some more results that may help in the interpretation of this also. The first is, there's obviously uncertainty in these analyses. So I'm going to show you 2 sets of sensitivity analyses. This first one is looking at guselkumab versus non-targeted. And you can see, obviously, the price of guselkumab has a big impact. There's some uncertainty around what the discount will be out there in the real world. While obviously it can certainly be above $150,000 per quality, it's possible that it could also be below, depending on that discount. And the quality of life estimates for patients who are either non-target or having response, there's uncertainty there, so that's also an important driver. Now, this analysis is a little bit different in that we're not comparing to non-targeted. Now we're comparing start with guselkumab versus starting with say, etanercept as an example. So this would be kind of a comparison looking at stepped therapy. And I think there's a couple important things to point out. The first is our base case estimate, where there's kind of that vertical line where all those bars are centered on. You're now kind of dropped a little bit below $150,000 per quality. So this would indicate, at least in the base case, that initiating with guselkumab would be in that range of 100 to 150,000 per quality. So could potentially be reasonable value. But obviously there's a lot of uncertainty here. Again, drug prices are driving that, and the quality of life estimates are important also. Now, not to make it even more complicated, but to make it more complicated, these are results where we run these simulations where we look at everything at once and we say, what's the probability that each one of these guys is the best value? Okay, and so what we have on our x-axis is our willingness to pay threshold. So those two dotted vertical lines are at 100,000 per quality and 150,000 per quality. On the y-axis is the probability that each agent is the most cost-effective thing, the best value, that's the one you should pick. And I think I'd just like to point out a couple of things. The first is that you can see these blue and gray lines that are up higher. That's brodalumab and infliximab. And this analysis is saying that kind of in that 100 to 150 range, those are the drugs that are most likely to provide good value. But you can also see that there's some other drugs in there in the mix. The IL-17s are in the mix. And in particular, it's worth pointing out that guselkumab, which I know there's a lot of colors here, but I think it's in a brown color there, is kind of in the mix there, a little bit with the IL-17s as potentially being a reasonable value. Certolizumab is actually down there, kind of at a very low probability of being a good value, based on, in particular, on the weight-based dosing assumptions we have. And the last thing I just wanted to point out is that orange line that kind of comes up and down, that's apremilast. So even that potentially at those lower willingness to pay threshold is potentially of reasonable value. So I know it's a little bit complicated, there's a lot going on, but we have a lot of agents here, and many of them have decent effectiveness. Yeah, I'd be happy to take a question.
Can you just talk about on infliximab, that drug is different than the other drugs in that clinicians have a much higher ability to change both the dosing and the frequency. So for this analysis, you base it on 5 mg per kid every 8 weeks.
Right, whatever the labeled dosing is, right?
Yeah. So I guess can you just comment on whether, because of the ability to really, unlike the other drugs, that you could really adjust the dose and the frequency, which will affect the price, how you might interpret that? Because that, to me, it could be very misleading that the probability of being most cost effective is, higher for infliximab than the others because of that ability.
Yeah. So by misleading, do you think that this would be a conservative estimate or non-conservative?
Non-conservative.
Non-conservative.
But I don't know if Alexa wants to.
Yeah, I think that the question you're posing is, do you underestimate the infliximab costs? Because in the real world setting, you would dose escalate over time to 7.5 mg per kg Q6 or whatever it might be, and that definitely happens. There are frankly not that many psoriasis patients on infliximab because the infusion is such a barrier for them. That said, you can also dose escalate here pretty easily to weekly. You can dose escalate Discontinuati to 90 in a low weight patient. So the studies suggest you can do that Q8. So there's whether payers pay for that determines a lot whether you get there. But I would say the big impact on this is, to your point, is part of the big loss in infliximab patients that you see that lack of persistence is in this base case where you don't dose escalate. So you have higher cost, but you also have higher persistence. So it would change the model.
Yeah. So I think you're raising a really good point, and probably one of the, as you'll see in the limitations, one of the trickiest issues is around kind of what happens in the real world. Dose changes happen with other drugs also. It's very difficult to model that because we don't have clear data on what that means for effectiveness. But generally speaking, these dose increases, most likely you're not getting a scenario where you're getting better value for money. Okay, you're chasing after something, and I feel like the way we've kind of handled it in the model is we basically kind of push people off the drug. We're saying if you're not doing that well responding, we're assuming you're discontinuing and going on to a second-line therapy. And so you got to remember we have that kind of boosted discontinuation rate for infliximab. A lot of people get pushed off that drug in the model, so that may attenuate your concern a little bit.
Yeah, I think that now that we have more options, we're more likely to switch than to dose escalating.
Yeah, and that's kind of what we tried to model based on what we heard from our experts.
To your point, dose escalating in those scenarios I talked about usually will get you about another 10 points on the PASI score and you double the cost. So most of the time when you have this many choices, from a cost effectiveness standpoint, you're better off switching, assuming rebates and other things.
Right, and I agree.
Which is why it's so hard to know the right choice, quite honestly, because you don't know what the right cost effectiveness choice is at.
Right, and I would agree with that statement. Yeah, I'd be.
I have a question. I hope it's not a stupid question. I've spent a lot of time on this graph and just wanted to ask why at any given PSA, sort of, you're running a Monte Carlo simulation, sort of counting them up. Why do the different lines not sum to 1 at any point vertically?
Yeah, that's a very good question. It's just because we didn't show the non-targeted option, which is just for clarity, but thanks for pointing that out.
So the quality measure that you used for achieving PASI 75 plus 0.9 in that range, and patients with this condition often have comorbidities, and I'm just wondering if that 0.9 is really achievable. And I know there's a sensitivity analysis around the utility input that was used, but it seems like it was a pretty tight parameter as well. So if we're talking about 0.8, maybe less than that, I think it makes these cost effectiveness ratios a lot less compelling. I think if you just maybe comment on the decisions around that input for utility associated with.
Yeah, no. What is the quality of life, and what is the quality of life improvement when you have these PASI responses? It's a tough question, and the data I would like to see is just measure the quality of life in the 2 different arms in the trial, and tell me what it is in terms of utility-based measurement. But we don't have that. So what we have is they've measured the patient's quality of life in the trials and then said, hey, what PASI improvement level are they at? So I think that these PASI estimates, they probably do reflect the underlying comorbidities of these patients. They use an instrument that picks up, it's a general quality of life instrument, EQ5E, so a lot of those things could have been picked up. I think there is uncertainty, though, and I think a bit of that concern has to do with it being a relative improvement measure, and then also kind of what's the improvement for a person who doesn't ever go on to targeted therapy and is in that non-targeted group. And actually, we don't have real good estimates for that. So there's some concern, I think, about the absolute measure. I think that it's the difference between non-targeted and response that's maybe where there's more uncertainty. And that's why we put wider ranges around those, and those all pop up in the sensitivity analyses as being important. So.
Most of these are based off EQ5D to that point. When you look at the questions on EQ5D, you could argue that 2 of them are not particularly going to be skin sensitive. So there is an ongoing conversation in the field of, is this the right utility for dermatologic disease? It obviously picks up some change because there's a lot of discomfort associated with these things, but some of the other impacts of social stigma and other things don't get picked up at all. And so you see that in the DLQI, but not in the EQ5D.
Right. So really good points, good questions. I feel like there's a hook coming. Pull me off stage here. So, yeah. So I just got a few more points to make, and we can continue the questions if you guys have questions. So we ran a whole bunch of scenario analysis. We tried to look at what would happen around, if you kept people on who only got a PASI 50 response, for example. We looked at different second-line drugs, et cetera. The things that really had the big impact were 2 things. One is when we included productivity offsets, which you can imagine people's productivity could be affected by this disease. It had a pretty meaningful impact. The ICERs dropped, but you can see here for these 2 drugs by about 12 to 13%. And in the case of guselkumab, dropping it below that $150,000 per quality threshold. So I think it is important in the big picture to think a bit about productivity impacts. And then the other was, you have this issue with the dosing for certolizumab and ustekinumab, and when you look at the lower dose of those drugs, those do fall below the $150,000 per quality. I think we've talked a bit about limitations, this discontinuation issue, dose changes, very challenging. Second line, we don't have great estimates for effectiveness second line. And again, these quality of life estimates, there's some uncertainties associated with them. We received like 50 or more comments, but some of the key ones I think that we did receive was just around dosing, cost calculations. We made some changes based on those helpful comments. We did not include specifically dose escalation just because of the lack of good data on that. And again, some folks wanted to make sure we did look at productivity, which we did in the scenario analysis. So I think just try to summarize everything here. I know there's a lot, but first off, guselkumab may be cost-effective at $150,000 per quality threshold. It really depends exactly where that discount falls, the drug cost essentially. For certolizumab, it depends how it's used in the overall population. Some people are getting double the dose for double the cost. You've got some challenging value issues there, but for the lower dose, it certainly seems like it could be in line with the other drugs. And then for our two drugs for which we do not have current prices, the threshold cost for those drugs, I think it's pretty easy to look at what the other drugs cost and kind of where they would line up. And really, I think they kind of need to be in that 25 to 30, all the way up to maybe $40,000 per year maintenance cost. And we have a table in the report, and we'll have a finalized table on that also. So with that, I'd be happy to take any more questions, although you guys have already hit on some of the key points, I think. Oh. Gotta use your TED Talk mic.
Have that on mute. This is okay. So, I guess specifically with certolizumab, I know that the two doses were combined in the network meta-analysis. One of Reiner's slides suggested that there were some differences with the higher dose in terms of effectiveness relative to the lower dose. So another potential limitation is that we assumed equivalent effectiveness for the modeling that may or may not be the case.
I think that's fair to say. I think regardless, if you run the analysis for the higher dose, it's going to be well above the 150 threshold. If you run the analysis for the lower dose, it's going to be below that threshold, regardless of that slight effectiveness difference that you may see there. Any other points or comments? Okay, thanks a lot.
Thank you, David. We'll now move on to